Welcome to the Health Leader Forge, where today's health leaders help to forge the leaders of tomorrow. I'm your host, Mark Bonica, of the University of New Hampshire's Department of Health Management and Policy and the Northern New England Association of Healthcare Executives. Our website is healthleaderforge.org, where you can find information about subscribing to the podcast, links and information related to the episode, as well as our complete archives. Today's guest is Dr. Michael Sherman, the Chief Medical Officer and Senior Vice President for Health Services at Harvard Pilgrim Healthcare. Harvard Pilgrim is a New England-based regional health plan with 1.25 million members. It has been ranked number one by the NCQA for the past 10 years. Michael holds bachelor's and master's degrees from the University of Pennsylvania in medical anthropology. He attended Yale Medical School and is a board-certified cardiac anesthesiologist. In the mid-1990s, he made the decision to pursue an MBA at Harvard Business School with the thought that he would seek to blend together his clinical expertise with a business education. But he was sure of one thing, that he would never work for an insurance plan. In this podcast, he tells the story of his career, about becoming a physician, making the transition to executive leadership, and how he ultimately worked for 3 insurers, ironically the payers he said he would not work for. Michael's career involves a great deal of serendipity, but it also shows his deliberateness as he worked to develop the skills he knew he needed to progress as an executive by gaining exposure and experience in a wide array of organizations. He is also quite candid about his successes and challenges, which shows that the road to senior leadership is never smooth sailing. His discussion of the work he is doing with value-based payment and bundling at Harvard Pilgrim is particularly useful and timely. It is very popular to demonize health insurers, but Michael's efforts to create win-win arrangements between Harvard Pilgrim and its partners in the provider community shows what is actually possible. It is interesting to see how his passion for developing these agreements meshes with a recurring theme of negotiations from different points in his career leading up to his current role. The podcast concludes with a discussion about Michael's leadership style and his recommendations for physicians who are looking to make the transition from clinical leadership to executive leadership. This is the longest podcast I've done so far, but Michael shares a lot of wisdom and insight throughout, and I think it's well worth listening to the whole interview. You are listening to the full-length interview. An abridged version of the podcast is also available for download. There is also a podcast timeline and links to the organizations and papers discussed at our website, healthleaderforge.org. Thanks for listening and enjoy the interview. Welcome to the Forge, Michael.
Thank you.
I'm really looking forward to our conversation today because you are the first physician executive that I've been able to have on the podcast, and you've also had a fascinating career in a wide variety of organizations. To start, you graduated in 1982 from the University of Pennsylvania with both a bachelor's and a master's degree in medical anthropology, with minors in molecular biology and chemistry. Did you know when you started at the University of Pennsylvania that you ultimately wanted to go to medical school?
I did intend to go to medical school and took all the obligatory science courses, and I genuinely enjoyed them, but happened to just out of interest take an anthropology class as well. And I was struck by how diverse it was and how interdisciplinary. And I don't even think I knew that the field of biomedical anthropology existed. So I started taking courses in human evolution and looking at genetic variants and how they might impact how individuals respond physiologically or to disease, etc. And there was a pathologist in the department who did autopsies on mummies, and that provided some learnings about disease today. How come we found heart disease but couldn't find cancer, for example? And so it really, I understood kind of intuitively how that connected to medicine, but I liked the fact that it had you thinking more broadly than just about biochemical pathways and the like. The other thing that came up, and this is just about the culture and environment, was that the typical pre-med at Penn was very head-down focused. if you looked at the grade posted at the end of the course, it was behind locked glass by the last four of your social security number. In the anthropology department, your test or more frequently a paper would be on a bookcase in a series of bins that you could go pick up at your convenience. So just a very different culture, and I thought it was a nice complement to the sciences.
Okay. And so after you graduated from the University of Pennsylvania, you attended medical school at Yale. This is a kind of a transformative experience for most people. So I'm curious, what surprised you most about medical school? Was it what you expected?
It was pretty much what I expected, but it also was an introduction into a system of education, which, although there were many positives, I also realized intuitively that there were a lot of improvement opportunities. So, for example, on the clinical side, you're frequently taught by individuals who are a year or two ahead of you.
Okay.
A third, fourth year student, you have interns and residents. Now, they're very busy people. Usually most of them were pretty helpful, but generally they've had no instruction in teaching or in leadership or management. And so, there was a bit of a lottery to what resident you were assigned to as a medical student.
Okay.
And I'd say the same thing as an intern assigned to a team. And so I saw a lot of opportunities for improvement in how they manage the teams and how worked with the students, et cetera. So that was, I guess, a surprise, but it's something that as I've gone deeper into management, I found that, healthcare, frequently clinical settings are some of those that have lagged behind other industries in terms of good management practice. The other thing that surprised me about Yale Medical School, and I think that just in terms of their admissions office, is they wanted to create a diverse environment in terms of interests. So I was surprised by how many individuals had other degrees or had other careers or had taken time off. So there were people there who had taken several years off to be in the Peace Corps. There was someone who was older who was a professional skier, someone else who'd been a professional ballet dancer.
Wow.
And the skier and ballet dancer ended up getting married, actually, I'm sure. And they have their own family practice center.
How neat.
In the Northeast. So it was just a really interesting environment, and I thought meshed well with my needs and interests.
Yeah, and you came in with a somewhat non-traditional major as well.
Yeah, I think I wasn't that calculating at the time I decided to get a anthropology degree as well, and again, by careful planning and double counting courses toward various requirements, I was able to do the master's and bachelor's in 4 years together.
That's pretty impressive.
Again, it was good logistical planning.
Yeah.
And so, for example, a course in human genetics counted toward the graduate degree and toward the undergraduate major and toward the molecular biology minor. So it was a lot of creativity and going summers and entering with some AP credit as well. But so that was I think at that point that also helped differentiate me, not just somebody with good grades, but some broader interests that they thought would contribute a different point of view to the environment and the community and the class.
Great. So after you graduated from medical school, you did a residency in anesthesia. What attracted you to anesthesia?
Well, there are a couple of things. So I practiced anesthesia, trained in anesthesia, and did fellowship training in cardiac anesthesia.
Okay.
So what I liked about that was, first of all, the immediacy. And as an anesthesiologist, you pretty much see the results right away, good or bad. And so that feedback loop is very affirming if you like what you're doing.
Yeah.
And I particularly liked cardiac anesthesia, where there was a lot more cardiovascular physiology and understanding how do you stop the heart, which is easy, and then how do you start the heart again after bypass surgery, which may or may not be more challenging.
So the anesthesiologist is actually doing that.
Yeah, there were things about the drug. Well, it's a team approach,
okay.
But your choice of drugs and whether you put an intra-aortic balloon pump or other technologies in is something you do with the team, and think about the choice of drugs certainly, and how you're ventilating them and certain other aspects. So the other thing that I liked about anesthesia broadly is that it was a good mix in my mind of the cognitive and the procedural. So I like doing procedures, but also all procedures and kind of less thought process around it wasn't attractive either.
Okay.
So as an anesthesiologist, particularly a cardiac anesthesiologist, you get to do a number of things procedural,
Yeah.
But you also have to really think about it and, understand, how you're calculating the systemic vascular resistance or cardiac output or other indicators and et cetera.
Neat. So it's not just kind of doing the same kind of cookie cutter procedure over and over. Every case is a little bit different and a little bit of a puzzle to solve.
Yeah. The other thing is in the program I was in, your last year of residency, if some of the residents, if you were fairly competent and had good leadership skills, were given attending privileges at the county hospital. So it meant that you actually were running the team and determining who was managing what case. This was a busy trauma center.
Wow.
Even determining which cases got priority over the other if there were more cases needing to go to the OR than others. So it was kind of my first leadership and management experience, and it was something that I found that I enjoyed.
Okay. I wanted to ask you, society holds physicians in a high regard, and being a physician is usually an important part of a person's identity once you achieve that. When did you really feel like you had become a physician? Meaning, when had you internalized that as a professional identity?
That's a great question, and I think it varies among individuals. For me, it was my last year of residency training.
Okay.
And I think as a medical student, you're not a physician, you're a doctor in training, and you're aware of that. And society may be impressed that you're a medical student. You're there thinking, how little do you know about any one subject?
Right.
And even when you finish in intern resident, you're still in learning mode. And you obviously you finish medical school, you're called doctor, you are legally a physician. But I think it's really a question: when do you feel competent? When do you feel confident that you can manage a situation? And again, that's not a point in time, that's a process. But I think by the time you're in your final year of residency and again, leading a team and managing others, and you're the one who is looked to in a crisis, that's when it all comes together and you develop that self-confidence and that cultural association.
Okay. So you practiced anesthesia until 1996. When you started an MBA program at Harvard Business School. What made you decide to pursue a business education at this point in your career? And what did you hope to do once you actually graduated with that degree?
Yeah, so that's a great question. The only thing I was sure of is I would never end up working for a health plan, which is where I am, of course, today. So that's the only thing I was sure of at that point. But
why was that? I'm just curious.
Because I view them as being about preventing the delivery of care and about creating barriers rather than the type of things that I actually do today, which are helping to align incentives and figure out how to allocate resources and put the tools in place to deliver better care. Yeah. Okay. But I'd say I didn't understand that then, but I also think the industry was different at that point. Okay. Where it was viewed very differently. So, it was kind of the early 90s, and I'm out there practicing and kind of minding my own business, and I should have been, I guess, satisfied. And so a couple of elements came together serendipitously. So first I became board certified, which as a physician is kind of big deal and kind of what everyone aspires to.
Right.
So for anesthesia, there is the written boards, which you can take right away, and then there's oral boards, oral exams, which can be a little more challenging, which you have to wait a while to take. So I took them, passed them right away, and that was obviously an accomplishment and kind of like a dog chasing a car. Now I've gotten the car. Now what do you do with it? Right. So I've been in academic mode for so many years. What's the next challenge? What's the next test? What's the next course? What more can you learn? Right. That it was hard to stop and get out of that mode. Okay. So I actually ended up taking at just a local university a couple of business courses, even economics and other things that I hadn't had the time for, and accounting. Really enjoyed those. And also, this was the early 90s. We had a healthcare reform version 1.0, Hillary Care, as you recall. Right. So the entire medical profession thought they would all be out of business within a year or two. And you laugh, but there was actually a collective sense of depression among many specialties about what the world would look like. And of course, the world did not end, and it's not ending now with the ACA. But there was a lot of angst, and I remember you had a lot of physicians going into sales or investment management or things that were tangentially, if that, tied to medicine, real estate. There was now again that was a bit of an overreaction, but there was a thought process of what do I need to do to be positioned well for the future.
Yeah.
There was also more going on in the business side. So at that point, there were some physician practice management organizations that were buying up practices, and they had names like Vicor and Med Partners, and many of them did blow up. Coastal Physicians particularly destroyed tens of billions of dollars in shareholder value. And they forgot some basic lessons, like once you buy a practice and the physicians aren't employees, they may not actually work as hard as they did before, but which again sounds
some agency
now.
issues.
Just some agency issues. So. But that was kind of the heyday. So I saw all this going on, and hospitals creating new lines of service and things. And I thought, I have an interest in that. I could be doing that, but I don't have the knowledge, and no one's going to take me seriously. You're just a doc.
Right.
So I need both to learn and to get some credibility.
Okay.
And I also just remember thinking how poorly managed many of the hospitals were that I experienced. And I remember going to a CEO of a hospital that had a new line of service in cardiac surgery that they had not before, and I was doing a lot of the cardiac anesthesia. And they hired someone from UCLA who, as a manager, a nurse manager. And she was terrible with the docs and terrible with her own staff in terms of how she managed, and very dictatorial, unable to collaborate. And I went to the CEO and I said to him, generally, I've seen something where someone is very supportive of their staff like them, the doctors hate them, sometimes the doctors love them. I've never seen anyone so completely alienate all the stakeholders. and he kind of laughed and didn't have a good answer, but I just saw so many bad examples of management. I remember as a resident, middle of the night, needing to replace an IV catheter in someone's neck, a central line. Mm-hmm. And I remember because I couldn't easily get that piece of equipment without having to page someone and do something that would take an hour in the middle of the night, I used a much more expensive full kit, as if you were doing this from scratch, which probably cost $500 instead of $100,
right,
because I could get it. And there were so many examples of just poor management, and I just thought there was a need, for more, which is really where the industry is going now. But again, in the 90s, that was there was less pressure. And some of those hospitals actually are no longer in business, by the way.
Sure.
I mentioned.
Yeah.
So I looked around and I thought about getting a part-time MBA. And I thought, and my assumption at that point was, I'll do that, I'll continue practicing, and it'll provide some opportunities along the kind of traditional clinical hierarchy around being a department chairman or doing something in addition to my clinical practice.
Right.
And that was kind of my plan. And then I remember there was one night I was up all night with this cardiac emergency, and it was 3 or 4 in the morning, and I think my circadian rhythms were off. I know my body temperature was off. I was cold. I had a blanket wrapped around myself, and I had this crazy idea, and I'd always gone to very good schools and and hadn't been thinking about it through that lens for a part-time MBA, and it occurred to me, everyone around you is talking about getting a part-time MBA, or it seemed that way. If you do that, you're just going to be a doc with a part-time MBA, and you're not going to be taken seriously. What are the best business schools?
Sure.
And so I kind of made a decision, or I thought of a decision, and then I kind of affirmed it later when I actually said, what if I apply to the top business schools? Let's just maybe give that a try and see what happens. Yeah. So did the applications, got into Harvard and Stanford, which are, I guess, hard to get into. And I didn't really think about it.
Hard is probably an understatement.
and again, I didn't think about it because I already had gotten accepted to a few weekend programs part-time. So I figured it was kind of on a lark. Let's see what happens. I took the GMATs and so went through all that and got in. And it's like, oh, now what do I do? And it occurred to me that it was a tough choice. I thought Harvard just had a bigger draw.
Sure.
And but they were both excellent programs. Yeah. And
but you were working full time, making good money, I'm sure, as a staff anesthesiologist. That must have been a tough decision to go into debt.
It was tough financially, but I also had this belief that it was the right thing to do, and I know I wasn't even sure that it meant that I would stop practicing after that.
Okay.
And I did practice again for another decade part time, but it just seemed it was a good idea. Now, my greatest crisis of confidence was actually the first day of business school, jumping ahead for a moment. And as a simulation, they put us in teams and had us making and selling greeting cards against other teams. And when I say making greeting cards, I mean with construction paper and glue and beads. And it was actually my wife who at that time she was with me. I dragged her all over the country, and we weren't married, but we were together then.
Okay.
And it was her birthday a few days after that. So my team made her birthday card with construction paper and glue and everything. And I remember being really depressed at the end of the day. And I remember thinking, I'm a board certified cardiac anesthesiologist. I was, in the OR doing valve surgery and now I just made greeting cards out of and that was so I did have a crisis that passed, and it fortunately and
did
it
you
was
see the value of the lesson eventually?
Yeah, there was a lesson in how poorly we actually worked together as a team.
Okay.
So it was, but at the time was kind of depressing. But anyway, so in making the decision, again, it was kind of tough. On the one hand, it was easy in that I figured going to Harvard Business School that's not going to be a bad decision, right?
Sure.
Worst case, if you on the other hand, financially it was tough. I had just started to get out of debt and hadn't yet paid off my student loans, which I just paid off a few years ago. Went into further debt, and again, at that point, this was in the late '90s. 2 years including everything was about $100,000.
Yeah.
And I actually thought I would practice part-time while in business school, and it was so the curriculum there was so demanding that it actually is something I didn't. So I got licensed, but I just never had the time to during that period of time. So, I made what was a very difficult decision. What was interesting is that my father is an oral surgeon, and he couldn't see it. He's like, "You're not doing this. My son's not a quitter." And I said, "Well, I'm not quitting. I'm going to Harvard Business School for 2 years." And he had a lot of trouble with that. And I think what happened is most of his friends, who are physicians or dentists as well, said, "Are you crazy? I would do that in a second if I could."
Okay.
And so he kind of came around, but it really took him a long time. But there was also the argument, like, can you afford? A lot of people said, "I'd like to. I can't afford to." And well, I mean, it wasn't. I thought that was kind of an artificial distinction. Yes, you'll go into further debt, but you can afford to do anything you want to. Just the question is whether you think it's worth it in the long term. And I just said at that point there was kind of just a belief that it was. And again, it took a while. After business school, you're paid in a management role by your value, not because you're an anesthesiologist. It took a while to get back up there, but it was worth it. And you need to be ready to do that if you're going to make that kind of change.
Yeah.
And then it's funny, a lot of the other physicians didn't believe, the people I worked with closely didn't believe it. They were like, "You're not," I mean, it was 2 weeks I was, given notice, and they were like, "You're not leaving." And they kind of didn't believe me until and then the hospital lead said, "We'll keep your privileges on." And I said, "Well, I'm resigning my privileges." And they were like, "Well, why don't we just put them on hold, or something?" And the people kind of couldn't believe, and you see that more these days. More people in non-clinical careers, but I think everyone just kind of had trouble believing it, given the point I was at. Now, jumping ahead today, it's interesting how many physicians and non-physicians, but physicians particularly, are looking to expand their horizons, going back for additional training, or even not. I know that a number of years ago, some of the consulting firms like McKinsey decided that they need to cast broader nets for expertise, and they've been known for hiring people other than just MBAs. And they interviewed at the top 4 medical schools, and they essentially did. And I heard from a friend that there was an informational session at Johns Hopkins, and he said he went, and between the medical students and residents and perhaps faculty, there were several hundred people in the audience at Hopkins wanting to learn about what were the opportunities if they were to work for McKinsey as a consultant.
So rather than going into a residency, they would just go straight to work for McKinsey?
Yeah, some were medical, others were residencies.
Residents already?
Others were, and I feel strongly that I did it, I think, the right way, in terms of first establishing myself as a physician, gaining that credibility, and then going to business school. And now you see more people going directly from medical school to business school and never doing a residency, or I've seen people leave residencies, and I get their resumes, and there are certain positions they can take, but they're not helpful in terms of any type of physician leadership role, because they don't have the credibility as a physician, the idea that physicians, nurses, others in a clinical environment will actually listen to them and respect them. So
it kind of goes back to what we were talking about your identity and establishing your identity as a physician. You said you had to kind of establish yourself. It was a procedure. You had to feel competent in your skills. If you've never practiced, then how would you feel
So again, it depends what you want to do. I mean, if you're in
Yeah.
investment management, it may not be critical, and
Yeah.
some people do that, and that's valid. But I also get resumes from others, and even you've got to have obviously an MD. You've got to have completed a residency. You have to be board certified to work in this type of environment. And some people have questioned. We've gotten resumes from people who are not board certified, and I've been very black and white. Absolutely not. Won't even consider them. And the reason for that is very simple. As someone in my kind of role, where I'm making policy decisions and decisions that affect over 1 million people, frequently there are those, such as physicians or hospital or others, who don't like the decision. And they're going to try to find every reason they can to impugn your integrity or capability if they don't agree with it, even if it's the right decision. And again, generally it's those who have dollars to lose in the argument. And if you do not have that credibility or are not board certified, they can point to you and say, well, you're in the role you're in because you could not cut in clinical practice. So I think it's very important for this kind of role to establish that credibility and to be able to talk intelligently and to have been in the trenches.
Yeah, absolutely. So you left business school and went to work for a company called DaVita, which at the time was the largest independent provider of dialysis services worldwide, somewhere in the vicinity of $1.5 billion in revenue. How did you find the position? And it sounds like it's a fairly significant management challenge for someone right out of business school.
Yeah, it's so one of the nice things about going to a place like Harvard Business School is the recruiting literally started my second week there when a consulting firm took me out to dinner. So, and again, this was new. I never had that type of experience as a physician. From the start, the recruiting at Harvard Business School is intense, and particularly intense the second year. I recall one interview with a boutique investment bank in San Francisco that was trying to hire me as an equity analyst. They flew a group of us out there to San Francisco for the weekend. Next morning we get up. They made sure we understood, don't wear suits, it's business casual, and they meant it. They were business casual. 6 a.m. we're in their offices, into half a day of interviewing. They then put us on a bus, took us to Napa, where we went to not one but 2 wineries, the second of which they had a dinner in a cave, each course having a different wine, except for the first course, which had iced Stoli vodka. And when you went back to your hotel at the end of the day, they had a bottle of wine inscribed with your name from one of the wineries. So wow. There was a lot of recruiting, and that was actually a good way to, you can joke, that was a very good way to get to know the people you might be working with.
Yeah.
So there was a lot of opportunity, yeah. And another point, had I not taken that educational route but tried to go a part-time or just try to grow through the ranks, getting a position like that it could have taken years and pain and so it kind of opens a lot of doors, obviously, and a lot of that is about the network as well as the education. So in this case, so first of all, the CEO was a Harvard Business School grad. I was taking a course with a professor. Her name is Regina Herzlinger, who's been something a mentor to me over the years. And she's amazing. She was the only professor at Harvard Business School focused on healthcare then. Now she's one of several, but then it was her, and her course was kind of standing room only to get into. And so I got to know her rather well. And she had the CEO, Victor Shaltiel, as a speaker, and she was on their board of directors. So she had an interest in to try to make sure they get the best and brightest. It was also a great company. It wasn't just kind of a boring operating company, but they were in high growth mode. So there was a chance to innovate, to take on many different roles, to take on more responsibility because they had very limited middle management. So it was a really hectic environment, but a fun one. So it was really Professor Herzlinger who made that introduction, and actually 4 students from Harvard Business School ended up going to that company my year, which is unusual,
wow,
particularly for an operating healthcare company, particularly then when healthcare was less in vogue than high tech.
Were your colleagues who joined you from business school, were they also healthcare background, or were you the only one with the healthcare background?
They actually did not have healthcare backgrounds. They had investment management backgrounds or finance or operations, and I ended up working on large deals with managed care organizations that may involve partnerships in building new centers and some merger and consolidation acquisitions, et cetera, and some quality programs and helping put together a physician network to manage the entire spectrum of care. Another colleague worked for the finance person, is now CFO of their dialysis division, and others in operations and in and mergers and acquisitions. So it was an exciting company, not that happened to be in healthcare. For me, obviously, I was going to do something in healthcare, but it was a great environment. It was fun and a lot of learning, and and again, it was really the Wild West. It was probably the least managed environment I've ever been in, because they didn't have there was very little performance management. We didn't have any travel policies. The CEO would say, "You're all free agents, get out there, do deals." So it was probably the least managed.
Wow.
And probably not representative of other places I've worked, but it was a fun environment and a high growth type of culture.
So this is your first, really, it's a clinical organization, but now you're in a management role.
Correct.
How is the transition for you? You're not being called on to practice medicine in this role.
Well, it's interesting. It was a little tough. And part of it was the mindset of management versus clinical, and I got that. But again, there weren't a lot of good role models there for me to follow. So to some extent, it involved finding your own way, and there were things I had to learn over the years. So as an example, there were some assignments I was given that were very nebulous. And in retrospect, I realized they were too nebulous. And what I didn't feel comfortable doing then was pushing back or saying, wait a second, I need some more clarity around what the objectives are. You've just come up with something very vague. What are the goals? What does success look like? And let's figure out what I need to do that. And I wasn't smart enough to do that, and I didn't have a good role model or mentor for teaching me that. Okay. So some of how you get things done in an organization were challenging, and then understanding the politics, and which is true anywhere, and who talks to whom, and et cetera, and kind of the informal influence networks. And again, that's something which I understood intellectually, but you had to figure out.
Yeah, okay. You stayed with DaVita for about 2 years, and then you moved to a company called Health Allies. What did Health Allies do, and what was your role there?
Yeah, so I'd been there about 2.5 years, and they went through a merger which unearthed some challenges, and the CEO wound up leaving.
Okay.
So once that happened, I think generally loyalty is to the people who recruited you, and the CEO had recruited me personally. Meanwhile, the whole .com boom was hitting, and so everyone was kind of moving around anyway at that point.
Yeah, that was an exciting time in the economy. Yeah.
It was. And so, a pattern that has kind of represented most of my career moves, someone called me who I knew through my network, and this was a classmate, actually a section mate then from Harvard Business School who I knew very well. And he said, I'm in an investment, I'm in a private equity firm, we just funded our own e-health company. Will you go talk to the CEO and tell me what you think about this? And I did, and met with the CEO, and he said, we're trying to, they have some web bill check product. You can go online, see if you pay too much for your hospital stay, and they can help negotiate something better. And I said, you should be creating a prospective marketplace for healthcare services. And he kind of said, you're right, we're working on that, want to work for us.
Neat.
So
okay.
Just kind of serendipitous.
So was that what you actually did with them?
Yeah, so I wound up taking the role of vice president for what we call provider business development, and eventually product management. If you're competent or semi-competent and don't complain too much, people tend to give you more responsibility. It's a truism.
Yeah, I agree.
But anyway, so it was kind of fun, and I really, this was a new role for just a very early stage company. Yeah. So I literally came in. There's no department. My office, we're in these temporary offices. There's a desk in it, and I think I had to scrounge for a chair and some other pieces of furniture. And I put together a team over a couple of years of 10 people and defined our strategy, which was about looking at healthcare services which were not traditionally covered by insurance. Okay. Think LASIK or IVF or cosmetic surgery. And we wanted to create a marketplace, and we'd go to the physicians. So think about a plastic surgeon. Some of them were not that happy about this new intermediary, and I pointed out, look, you're currently spending money on getting business. They don't like to use that term, but it may be running an ad in Boston or Los Angeles magazine or wherever you are, or whatever, but you are spending money to acquire patients. Instead of spending that as fixed cost, give our people a better deal. And you can decide if it's 5 or 10 or 12. You can vary it over time of the year or time of the day or whatever. and it doesn't have to be everything you offer. So we're being very friendly, and through our web portal. This was back in around 2000, so this was different. We'll give you the ability to sell your benefits and what differentiates you, and have it be not just about cost, but about what you do better and why it's better, et cetera, and how you connect with people. And again, you've got to give our membership a better deal, but you can decide how much it is, and then they can decide through this portal who they're going to go to.
Wow.
And so I was really stocking the shelves by going out and working with the physician societies and individuals in large groups, identifying what the right specialties were and negotiating the deals with them. So again, it was good for someone who was a physician, but it was also the business skill set that really was being leveraged there.
So it was important that you were able to bring the credibility of having been a practicing physician to this position.
Yeah, but most of the people I hired, in fact, none of them were physicians. They were people who, most who'd been in healthcare, who'd worked in a hospital setting, maybe in contracting, or some had other clinical backgrounds or legal backgrounds, but they got healthcare. They'd gone through bachelor's or graduate programs that provided some experience, but most did not have clinical backgrounds, but they understood the healthcare environment.
So after you worked at Health Allies for a couple of years, you made the jump over to a company called Immusol, I think, which was later called Itherex.
Yes.
In about 2001, and this is a biotechnology company, so something very different.
Yeah, it was, and again, very unplanned, and my approach has always been do what you like, focus on the skills, and kind of the opportunities we'll find. Do a good job,
yeah.
Be known for integrity and for delivering results. Things find you. So what happened is, first there were two things that came together here. One of which is we had really been successful in growing what I wanted to grow, and it was selling very slowly. This was in the early years of consumer-driven healthcare, and there was very little revenue coming in. So we ended up actually significantly downsizing the company, and it ended up getting sold after a bit of time to United Healthcare. Mm-hmm. But there wasn't a whole lot left to do, and it just, the revenue wasn't coming in.
Okay.
So
an interesting idea, but maybe ahead of its time.
It was ahead of its time, and again, it got purchased, and they embedded that in some of their offerings. So we were faster. We did a better job of recruiting providers and then getting people to pay us for that. And there's actually a Harvard Business School case study on that, which talks about the challenge. And a lot of it was really about the difficulty and getting a brand with an individual, which is how they started. We want to sell this to individuals, and they then decided late in the game it should be sold as an employee benefit, which was smart, but okay. In the days of B2C, business to consumer, people, we didn't get that initially. Mm-hmm. So I was open to new ideas, and I got a call from a colleague, a business school classmate, and he was actually co-president of the HBS Healthcare Student Association with me. So we knew each other well. We'd kept in touch. And he actually had been in biotech, and he just had recently joined this company called Immusol as head of business development. And he was trying to get me to join them as head of medical affairs. And this is something, in retrospect, I think it was a good experience. It probably wasn't a good choice. I'm not sure I would make the same decision again, but it was good experience and good learning. Okay. One of the learnings was that I didn't really know enough about biotech to choose the right winners and losers. So, okay. Investors in biotech pursue a portfolio approach, right? You would never buy one biotech stock. Yet, in looking at a company with one product, essentially, you're making that bet with your career. And again, there was a lot of upside and equity, which probably swayed me, but ultimately I was
very alluring, right? The possibilities there.
You could be very, but I probably did not sufficiently understand the risk profile, nor the fact that there were a lot of small companies and up and down the street, even where that was located in San Diego, and within 2 years, most of them were out of business. So this was a company, though, that had some proprietary technology and had been using it to develop essentially drug targets. So they were selling these tools to pharma companies like the Pfizers of the world or Novartis, and they were using these tools to develop drugs. And there was a compound, an entity that was anti-proliferation. So the thought was it could be used, to treat certain proliferative diseases, even maybe cancer or psoriasis or other things. And so what they wanted was someone who could, the buzzword was forward integrate at that point. So help us go from being a company that delivers to services to bigger drug companies to developing our own drug. And as I told my friend vigorously, I don't really know anything about this. This is so not in my bailiwick. And and he did a very good job of selling me. And he said, look, first of all, the regulatory part, let's just agree you don't know anything about. We'll get some consultants to help you figure out the whole FDA thing. And which is actually a good lesson. If there are parts of the job you don't know, surround yourself by staff or others who can fill in. That's a good lesson any time. But then the way he framed it, which I finally got, was it's not, you may feel you don't understand biotech and that you lack the competencies, which I thought I did. But for a company in this stage, what you really need to do is take this potential drug, get it through to approval, working with the rest of the team, and then create a clinical trial network. Get out there, get the best and brightest, develop the protocols, and to work with the best and brightest. This was for an indication, proliferative vitreoretinopathy, so it was an eye indication, and working with the best and brightest, and I did that. So that was a skill set I thought I had based on what I had done previously. So it was a different environment and a good lesson here. So if you framed it not as I'm going from a consumer-driven healthcare startup to biotech, but I'm going to something where I was trying to sell physicians on why they should work with us, to something where I was trying to sell physicians on why they should work with us, and for far less than the other larger pharma were paying for the same trials, generate the excitement, get the right people, et cetera. That was a skill set I thought I had, and I was successful in putting that together.
Yeah.
Now, what I probably didn't appreciate at the time was that we were underfunded for what it would take to get it through, and I ended up very frustrated with the CEO because the size of the trial was, in my mind, insufficient to prove that it worked. And sure enough, the results were equivocal, and the company ended up floundering for a couple of years and ended up failing eventually. Mm-hmm. But it was underpowered in statistical sense to actually deliver what we had hoped, and they were hoping to show a trend, et cetera. But so we don't know if the drug worked, but the trial was underpowered. But it was so it was frustrating in being in a startup that was under-resourced for what they wanted to do. And again, one of the lessons there is just because the CEO and board don't know that or won't acknowledge it doesn't mean that it doesn't mean they're smarter than you are necessarily.
Right.
So there was some faith that there are all these really smart people there who knew more than me, and that I should trust that as an indication that a lot had been invested in the company. And the lesson there was trust your own intuition and common sense, and don't always believe, don't always drink the Kool-Aid.
That must have been a unique experience, just adding this experience of working with the FDA on this kind of approval process. This is such an important part of the healthcare environment to really be having had an intimate experience with it.
Yes, so the benefit wasn't so much the company itself. It was in my role now, and again, that we live in a complex ecosystem. And it's being able, now that I chair our P&T committee and are dealing more with high-cost drugs, to be able to understand that process and how the pharma companies think about this, and to be able to understand how those fit into the mix. So it was valuable learning for what I do today, even though I didn't know that was the case at the time.
Sure.
One of the challenges, again, we have a very complex ecosystem, and it's important to get experience in, depending on what you want to do, in enough aspects that you understand how the pieces fit together. You don't have to be an expert in everything, but you need enough knowledge acquired through education or experience that you understand the environment and the regulations and how the pieces fit together. For example, I interviewed an MD the other day, an MD MBA, who worked exclusively in pharma companies since getting his MBA. And he very impressive individual, very, very bright, best schools, but he didn't actually understand anything about how payers make decisions, which is surprising since he'd worked in a pharma company. You would think that, but how we make decisions, how we construct formularies, how we work with physicians to try to influence the choices they make, etc. So at the end, I was intrigued by his background, but he had so little understanding outside of his niche in healthcare that there wasn't a clear role for this individual within our organization, which is what he'd been hoping for.
Okay. So you left Immusol and went to yet another very different company, and that was Thomson Reuters.
Yes.
What was Thomson Reuters, and what did you do for them?
So that was a very calculated move, unlike some of the others where things just happen to come up.
Okay.
And so, at that point, I realized that the company was lacking in leadership, and that was unlikely to be successful. And there's also a lesson when all of your colleagues come to the same conclusion as well, and they had a large exodus of their senior management. Yeah. But so I was thinking very clearly about what I wanted to do next, and I have this background as a Harvard MBA, and really was looking for the right mix of business and clinical knowledge, but I really had more of a business hat on. And so what I was looking for specifically was a general manager role in a healthcare organization.
Okay.
And this was a true general management role, which is, I think, what many aspire to. And so there are some cases where people see you're an MD and assume that you're just the guy giving it. Well, it was very clear you owned the P&L, you owned the line of business, the sales, account management, marketing, etc. And that's why that was attractive to me. And again, it wasn't necessarily more money. I had to move from California to Ann Arbor, which probably my wife would not have suggested it if not for the career opportunity. But it was also with a very well-run company, a part of Thomson Reuters. They since have divested that, and it's been spun off under a private equity firm. But it was a division formerly known as MedStat, then became known as Thomson Healthcare. But it was kind of their crown jewel, a very fast-growing, exciting company in healthcare analytics.
Okay.
So I was general manager of their payer business.
Okay.
And for their health plan line of service, if you would. And what they did is they served payers like ours and others, and provided the software, the analytic software, and consulting services around that, the solutions, I like to think of it, that help people in my position look at all of the claims information we get, which tells you what a doctor's office visit cost, or what was spent on surgery, or what someone's blood value is, and make sense of it. Taking that data and making it into actionable information, grouping it together so you can compare apples to apples, for example, and find variance and make good management decisions. So again, I never thought I'd be in a CMO role or medical director role even, but and I didn't realize how valuable that would be to me. But at the time, I was attracted less by the specifics of the industry, although I thought health IT was very interesting intellectually. But more because it was a general manager role with all of the accountabilities under it, and that's what I wanted to do next.
Okay. That's, you were drawn into analytics. This has become a major buzzword today.
It has.
It must have been kind of the early phase of that. It
was earlier. Some of our customers didn't have analytic platforms and needed to be educated on why those was important. Today, with more pressure around cost, more pressure to figure out which high-cost drugs are the right ones and where they needed, a lot more collaboration with physicians. I mean, if we're doing a bundle payment for a total knee or for CABG surgery, for example, all of which we're doing, and you want to figure out what's a fair price, what goes in, what are the components, and show the physicians what makes sense. You need to have the data put together in a way that can illustrate what goes into the bundle, what have been the traditional costs that go out, that are paid out over varying periods of time, so that they can understand what they're taking risk for.
Okay.
So,
one of the things that you noted that you did while you were at Thomson Reuters was you introduced a negotiation curriculum. What was that about, and why did you implement that?
Yes, so it occurred to me that we worked really hard to sell business, and we were under a lot of time pressure, as you always are in that kind of role, around the quarterly earnings or something. And I thought that people were getting outsmarted by the competition. And at the end of the day, when it came to negotiate it, we were ineffective, and we were leaving a lot of money on the table. And also the business I picked up was running off of what they should have been. They were up behind targets for revenue and operating income, which was how my incentive was based on. So I was very motivated. So I started putting something together for my people, and then I was asked by the organization to put together a 2-day curriculum for the senior leadership for everyone. So it was something I only anticipated for my group, and then ended up kind of drafted to do it more broadly. But I think we realized that it just was something that people had not thought about systemically, and some people were stronger than others. But generally, it was not a core competency, and it was more so for our customers.
Yeah.
One lesson I had learned even prior to that, when I was at DaVita, they were very focused on selling business as a revenue-driven company. And we were working on a joint venture with Group Health Cooperative, which involved building some dialysis centers in their hospital and some revenue shares and some other things, because it was a certificate of need state, and this company could not move into that state without a partner. And it was a good approach, and it was the right approach. And Group Health Cooperative had a hospital that they built 2 or 3 years ago, and there was a floor that was not even built out yet. They had unused space. It was like on the 5th floor or something. And they liked putting the center there. It would be easy for their nephrologist to put the dialysis center there. And they negotiated very strong around the pricing for that. We paid top dollar for that rent, if you would. And we had someone who was more with a sales hat who was driving that. And I was against that. I thought we were getting outmanaged there. And and they wanted to get the deal closed. And I remember pointing out, this is the 5th floor of a hospital that's sitting vacant for 2 years. What are they going to do? Put a McDonald's in? Or a retail store? We should have gotten a much better deal, and we agreed to some other things, and then they wanted some other things and some other revenue share, and it became, I thought, less of a good deal. And one of the lessons to me was we had a closing party, a dinner, up in Seattle that everyone came to celebrate when it was actually signed. And some people on their side had a bit to drink, and they were laughing in our presence, saying, we just kept asking for more and more, and you guys kept saying yes, and and we were waiting, and finally I said, no, we're not doing anything more, and I really pushed hard, even on some people more senior than me, but I said, we're done. We're, to the other people, I said, we're beyond done, and this deal's not going to. And they said over drinks, oh yeah, we just couldn't believe you kept saying yes to this. And it was a reminder that you really, need to be thoughtful. And again, I had taken negotiation in business school, so I did have some formal training in that, and I just observed a lot of mistakes that were being made. So there are many examples like that.
Yeah, sure. Sure. So as a general manager in a general manager role, one of the things you're really responsible for is kind of developing a corporate culture for your organization. What did you strive to do? I picked up on the negotiations, a piece of that possibly, but how did you see, what kind of culture were you trying to build?
A culture, broadly you want a culture of accountability, but also one where people feel valued and where they have a chance of winning, and where their efforts will be rewarded, but also understanding it's not enough to come to work every day. You need to meet your goals. And so we had a couple of challenges there. One, this organization, back to its roots, prior to being acquired by Thomson Reuters, had been very academic. I mean, up until a few years before I came, they still had sabbaticals, which are unusual in the business world, paid sabbaticals. So one of the things that you needed to instantiate was a culture of, and I put it this way, and when I met with very senior Thomson people where I flit, that they liked what I was doing. They completely got it. I said, we need more Wall Street Journal, less health affairs. And they got that immediately. In other words, a lot of times people would be, I'd say, what do you hope to achieve? Oh, we'll get a publication out of it. And I'm like, well, my goals are revenue. How does that help? And how does that help us? So there was a bit of an academic environment and a little bit of, here's the right way to do it, and less of, let's focus on what drives revenue and business growth and success. And again, success may mean different things in an academic versus non-academic, depending for profit, not for profit, but it's ensuring that everyone understood the goals and having a more defined strategic plan. And that's, ever since then, I also have done more to develop a more clear strategic plan myself and those around me to make sure everyone has buy-in and understands what the objectives are, et cetera. So that was part of it. There was another part there which I don't know that I was ever completely successful at changing, and that is some of the expectations, and this is sometimes you find in some profit-driven companies, they were difficult and sometimes impossible. And so what I also wanted to do was drive a sense of accountability while being reasonable. If people feel that you're not being reasonable as a leader, you lose credibility immediately. So for example, I had 3 account teams, each of which had certain objectives for selling additional business, like consulting services or additional tools. And one of the 3 teams, the lead came to me and said, I can't do that, and can you change that target for me? And I listened to her. So part of the lesson is listen to what your people say. And what she said was very reasonable. And what she said is, what you've done is put all the Medicaid health plans in my area as opposed to others, and the others have these more commercial plans. My health plans, which are funded by the state, they don't have any money. So you can give me a target of whatever you want, but they don't have any money to spend on more things. And I said, you're right. And I changed the allocation and released that. But it was, there was a bit of trying to create that culture within my organization, where the broader organization was very tough and not always reasonable. And ultimately, that's one of the reasons I left, was that I felt ill-equipped, and that I could not change that from an organizational perspective.
Between the organizations.
And again, they were under pressure from the parent organization, Thomson, et cetera.
Sure.
But again, one of the lessons about leadership, was really understanding what you can and can't impact. And if you're in a situation where you don't feel you're aligned necessarily with leadership, or can manage without saying, the reason I'm doing this is because my boss said I have to. So that's, when you're in that situation, that's a sign you maybe should think about other opportunities.
So you did leave Thomson and you moved on to United Health.
Yeah.
What were your roles there? You did several roles there.
I did. So again, that was very turbulent as well. It was interesting. I learned a lot. And even the way I got recruited there was kind of interesting. So I had been thinking about leaving, as I mentioned, because some of the cultural elements were not, made it hard to put in place the kind of culture I wanted. Right. And I got a call from a recruiter at United Healthcare, and they actually wanted to buy our company, and Thomson didn't want to sell, so they were aggressively trying to pick off people. And I kind of said I view them as kind of this evil empire.
United Health?
Well, at that point. No, United at that point.
Okay.
And again, I didn't once I got there, but we competed with part of their business.
Okay.
And, they were reviewed as being kind of a tough
Well,
environment.
they're an enormous company.
Yeah, they are, and they were, and they are even more so. So I didn't really. It never even occurred to me to go there, and it would probably not have looked. And I got a call from a recruiter and said, I understand from your background you worked at this other startup, Health Allies, and I said, yeah. And they said, oh, yeah, and they'd acquired Health Allies.
Right.
And they said, do you know this person who was one of the key people there who'd stayed with them? And I could afford to be a smart ass. And I said to the recruiter, I don't know, that depends. Do you like that person at United? And they said, oh, yeah, he's very well respected. And he's in a senior role at now, even more within United. I said, in that case, I know him. And so, 10 minutes later, the phone rings. It's this person. They're in kind of recruitment cell mode.
Okay.
And next thing, they're trying to find a position, offering, that is interesting enough for me to go to.
So they were really looking for you,
yes.
Not necessarily to fill anything particular.
At
They just
that
wanted
point,
you on a
yes.
team.
Yes.
Neat. Okay.
Which is a good way to hire talent,
Yeah.
actually.
Okay.
And so, make a long story short, United, if they want to recruit you, will.
Okay.
And they're flying my wife and I and showing us homes, and saying if you have trouble selling your old home, we'll buy it. I mean, they made it. They removed any barriers.
Okay.
And so I went there, and it was overall a good but a very turbulent experience. And they're a solid organization, very well managed. So I learned a lot. I learned a lot at Thomson also about good management. I mean, it was a tough organization, but about setting targets and around performance management and strategic planning. I mean, they really did everything the right way there. And after a couple of startups and company DaVita, which did it on the fly, it was something I actually needed to experience and needed to learn.
Okay.
So that was, and I learned quite a bit of that at United as well, really about being focused on the objectives and et cetera.
Okay.
So the only challenge with the United was, so they recruited me into a role in helping roll out the new Part D business, which was brand new then in 2006. It was mid-2005, so it was building for that. And as being part of that senior team, and it was, again, very exciting and intellectually challenging. I knew I'd learn a lot. The only problem there was that a couple of weeks after I joined, they mentioned something that they didn't bring up during the recruitment process, and that's they were about to buy a small company called PacifiCare. And as most people know, any merger, particularly one of that size, creates chaos for a long time as you try to figure out how the pieces fit together. And it created a lot of chaos. So I was in that role in Part D for a little under a year. And then they came to me and said, and this is how big companies work sometimes, and they said, we had the president of the Part D business for United and the president for PacifiCare. And we didn't know what to do with the president. We decided we're giving the president role from United to the United person for the combined entity, and we couldn't figure out what to do with the PacifiCare guy, so we gave him your job. I'm like, oh,
okay.
Really? that's interesting. What do I do now? Oh, you can go over to Ingenix, which was a part that competed most closely with where I'd been, which is really where they wanted
Thomson.
me. Which is really where they wanted me in the
This
first
was
place.
the evil empire side.
Yeah.
So now you're in the evil empire.
This is actually very calculated that I wouldn't go to that company, but they recruited me and then moved me over.
So once you were in,
I'm like, do I have a
they had
choice?
you.
Well, no. So I'm like, okay. So I went there, and again, it was interesting and chaotic. Ingenix, now part of Optum, is very high growth, but it was also kind of we'll find a role for you. So I actually had 2 or 3 jobs in under a year, and at that point there was so much turbulence that I felt it was hard to get things done. In one case, I was put in charge of several businesses and went in and said, here's our 3-year target to grow revenue, and they kind of rolled their eyes. And it's because I was the 5th person in 5 years who'd been trying to teach them that. So they were growing so rapidly then that I think they were spending less time on managing and on thinking how they put the pieces together.
I see.
And so I said, I want to get out of here. And this is, again, part networking. I went to the chief medical officer for all of United, who I'd become friendly with, and I said, Reed, got any suggestions? Because I'm kind of frustrated. And so he said, yes, they were doing some really innovative work on different payment models and medical home, et cetera, and let me introduce you to so-and-so. And I wound up doing some work on the primary care line of business side. So the interesting thing here is I'd never intended or wanted to work for a traditional commercial health plan, and I end up there, not intentionally, because I was looking to make a move out of one area of the company to another. That's what it's about, and I became sort of working in this medical home area, which has become very big and very timely. I didn't know that then,
right?
But it was all about the start of how do we go from telling docs what not to do and what to do, et cetera, to creating incentives and aligning with them and collaborating and finding ways to pay them more for doing things that create value, which is really something I'm passionate about.
Yeah.
So I did that for a while, and Humana then had a role which it came to my attention. It was a new role, and I felt that I was kind of moving all over the place within United, and it was unclear. It still appeared to be very chaotic. So I was craving a bit of stability, and so I'll also add that I do a lot of things right, not necessarily in the right order. So now here I am, 54, and I have a daughter who's 5.5. So at that point, I felt like the time was never right, focused on the career, and then all of a sudden it becomes important as you get older. So the other thing that was going through my head is, I don't want to move every couple of years now. I want to think more clearly about the environment and more stability, which, again, earlier hadn't been important, which was a benefit, I think, in career management at the point. But so this opportunity came up with Humana, and what they wanted was someone to develop and manage a new department, which is something, I like doing, physician strategies. And the idea was to be a department that really worked closely on developing different models for working with physicians, like medical home or different types of pay-for-performance or other models that align incentives and got away from the fee-for-service, and this is becoming more and more important. But this was, for a step for Humana. And then the other thing is I was worried about whether it was a big enough role for me. And so in the discussion, they agreed to make it a more robust role by also moving oversight for their medical directors, what they call their market medical officers, not those doing reviews, but the outside-facing medical directors who were across the markets. There were about 15, and they moved them under me from a dotted line perspective. So they reported into the market presidents and had a dotted line into me. So it provided a more robust role, but also, since the pilots we were trying to develop needed to be done somewhere, it also provided kind of distribution for that, if you would. And so it worked well together, and I built up a team there and hired people, including people who had worked for me before. It's something I'd done at United. It was something I did there. I've learned if you develop a reputation for integrity and people trust you, they'll follow you, and you know which people you want to recruit away.
Yeah.
So that was very helpful.
So is this the first time you're managing geographically distributed
yes.
organizations?
Yes.
How was that transition for you?
It was challenging, but ultimately I think it went well. Matrix organizations are tough, and one of the challenges with that was the fact that in different, what I realized is the medical directors, their experience was determined more by the market than by me. So I could try to create a culture and really create almost something where I want to be viewed as a coach and a resource and an ally versus top down, because it was dotted line. You really had to manage by influence. So, but the fact is, if you think about their lives, I might speak with them and do a call weekly, and try to visit them at least, and chat with them and visit their markets once or twice a year, and bring all the medical directors together, let's say twice a year. So I was trying to do my part to build the right culture and the right incentives. But if you think about it, if you're in the New Orleans office as a medical director, you're going to work every day in the New Orleans office, and you're working with their salespeople and their market presidents and others. And so what they experience in terms of a culture and in terms of just the whole environment is determined far more by that office than by me.
Right.
And different offices had different cultures. You might imagine New Orleans and Arizona and Illinois, very different in terms of what's considered appropriate, as you might imagine, in terms of even alcohol consumption, which you can imagine, New Orleans Mardi Gras time. Yeah. I used to like to visit that office. And then the market presidents, who also significantly influenced their experience, also were very different. At that point, Humana was trying to move from market presidents who were salespeople to those who were general managers. So again, sometimes the medical directors were challenged by how they worked with the market presidents. And then you had market presidents who were very good at collaborating, which is what you need in a matrix organization. And there were those who said, just take your cue from me. Yeah. And you don't have to listen. Don't listen to anyone at corporate. We need to work around them. Yeah. So what I found, there were big differences, and you did your best, and tried to build So I worked hard to build relationships with the market presidents and with their bosses, the regional CEOs. So whenever I visited market, I spent time with them and made sure we agreed on performance goals and built that sort of relationship as well, which I thought was important, and which helped over time, get to a better point. Particularly as some people left and I became involved in recruiting. And anytime you inherit people, that's another lesson. Their loyalties may or may not be to you. And when you hire someone from scratch, you can kind of build that relationship and make sure you're getting the right person, which is a good lesson to learn early on. The other lesson from Humana was understanding where the opportunities are, and that the job as defined by someone else may not be the way to do it best. And that's on you, not on your boss necessarily. Okay. So in this situation, Humana, my role lived in the commercial organization. That's where they recruited me. That's where I reported up. And I quickly realized that Humana was challenged in the commercial area, but really hitting it out of the park in Medicare Advantage. And even looking forward, a number of years to just now, 2015, it's just been announced that Humana is being acquired by Aetna. And the reason is for their Medicare Advantage business. If you're on the commercial side, you may be looking around for something different to do, but it's really for the Medicare Advantage business, where they're strong. So even at that point, though, I realized that is where they were stronger. That's where the growth was focused, and that's where they were making most of their money from a business perspective. But I was on the commercial side. Okay. So what I did is I created relationships with a Medicare organization, starting with the Medicare CEO, and I realized the type of things we're doing for commercial, improving value, decreasing cost, improving quality, are equally important for the Medicare population. So even though I didn't formally report in there, one of my personal objectives was to have them I had to educate them what we did. And before you know it, they had me speaking. They'd be pulling together their whole leadership, which could be 300 people, and were giving me time to talk about what I was doing, and featuring me on calls with their leadership. So, and it was really about, here's what I'm doing, and here's how it can help you. Again, this needed to be not, here's what I'm doing. That's also a mindset change. It's not, here's what I do, but anytime you speak before a group, understand what they want out of it. What aspect is of interest, and then think about how you position that. So I'm like, here's the things we're doing, here's why you should care. And so before you know it, we're doing a lot of these things for Medicare too. So I saw that white space, and rather than have them create a team themselves, which could have happened, they had some duplication in Medicare versus commercial because they were set up consciously that way. I said, we're a corporate resource, and even though the people I reported up to didn't always appreciate it initially, it turned out after some restructuring to be a very smart move.
Sure. Yeah.
So we supported them as well, but it was something which I led rather than was told to do, because I saw that as a need.
Okay. So at Humana, you were working really kind of on this idea of value-added as opposed to, and trying to get away from kind of an encounter-based fee-for-service. What initiatives were you really putting into place there?
So there we were looking at things like medical homes, which pay additional care coordination fees to practices for doing things differently that deliver value and which themselves can reduce, hopefully, ER visitor hospitalizations. So the whole point, we were doing other things around pay for performance similarly. So the whole point was in thinking, if the system is set up for fee-for-service, which everyone agrees is probably a bad idea, not how you would design something from the scratch. I mean, there's a reason we're across the world seen as a low-value system with high cost and outcomes that are not where they should be. And it's that we pay for the wrong things. So I think most of us agree that we need to move toward a different types of payment system, but it's easier said than done, particularly if you're talking about provider entities that are built on fee-for-service. If you go to them and just try to get them to do things that reduce ER visits or readmissions, et cetera, again, they may agree intellectually they're the right things to do. No one is in favor of readmissions, but it hurts them financially. So it means that they may not actually be as effective in managing it and certainly aren't going to spend a lot of effort on that. So it's one of the few industries where rework means you pay more. I remember that as a fellow where we had someone who's having a revision of their bypass grafts, and it's because the surgeon had bypassed the wrong graft. That's a big deal. In other words, they bypassed a healthy vessel and missed a diseased one. That's a really bad error, by the way. And then afterwards, the patient had chest pain, and they realized, oops, that should never happen. But it did happen. But the system paid again for the corrective surgery, as opposed to, which is nuts.
You broke it, you fix it.
And, the other thing, which I guess influenced me, and it's funny how the pieces all come together at some point. So when I was in business school, one of the, and they were all great courses, but one of the really, really important courses I took was something called CCMO, Coordination, Control, and Management of Organizations. And it was really a lot about thinking about the incentives that are in place and what it means for the costs incurred by different parties and how you create the right systems, whether related to sales compensation or CEOs or equity ownership, et cetera. And so we talked about things like, how come senior leadership wants a corporate jet because most of the cost is being borne by other people, et cetera. And so think about these kind of incentives. And the course focused heavily on many of these. And so, it's clearly you get into healthcare and you realize that these sort of lessons, which most other industries have learned, are not being practiced in healthcare. And now as we've gone forward with the ACA, which is, I would say, insurance reform, not healthcare reform. So the good news is we've given access to care to many more people. But the bad news is we've given access to a high-cost, dysfunctional system to many more people. So now there's much more pressure to driving toward value, since we're at a point where you read about premium increases and that's because care is expensive. And we're at a point where with these high-cost drugs, for example, either you individually are paying for it or everyone is paying for it. And the idea that the payer is paying for it isn't really true because the money's coming from one of those two sources. But we're under more and more pressure now in this environment to think about how we manage expenses. And again, what we want to do, we don't want to be in the business of saying yes or no, particularly when we're not in the exam room with a patient. We'll look at the evidence and put together policies in place that reflect evidence-driven medicine. But at the end of the day, the doc is in the exam room with the patient, and they're in the position best to influence this. If you want to think about how best to influence care, think about the right policies and tools, but also about incentives that reinforce that. And that's a lot of what we're trying to do with how we work with different systems. And so if you look at what we're doing, so we were taking baby steps at Humana. Now it's become even more important, both for Humana and all the payers and for Harvard Pilgrim. And one of the reasons I took this particular CMO role was it's really where they wanted me to focus.
Okay.
And not just on utilization management and more of saying no on the nuts and bolts and maybe stuff, but thinking strategically, how do we make the system work better?
So let's talk now about Harvard Pilgrim. So you spent about 4 years at Humana, and then you made the transition over to Harvard Pilgrim, where you are here today.
Yes.
So before we talk about your role, can you tell us a little bit about Harvard Pilgrim Healthcare and kind of what makes it special?
Yeah, it really is a unique organization. We're not part of Harvard University, although it was actually created by the dean and spun off a little over 40 years ago, the dean of the med school, but it technically is not part of Harvard University. They are a customer, but we have to compete for their business.
Okay.
We are a not-for-profit insurer. in recent years very not-for-profit, but I think it's a positive, and our stakeholders understand we care about doing the right thing, and we want to make a little margin so we can stay in business and invest in new areas. But it's not about returning dollars to shareholders, which I think is an advantage. It's about using dollars for medical service.
Yeah. And this is a contrast to Humana, which is a for-profit public company.
Quite, yes.
Yeah.
Yes.
Okay.
So it's nice not having those things impacting your thought process and being able to beef up. But we still need to break even, or a little bit better, hopefully, and manage medical expenses for our employer customers, because the markets, exchanges, employers, they've had enough of rising costs, and they expect us to be doing something. And more broadly, if you think about how the environment is reconfiguring, if we don't deliver value, why should we exist in this new world? So if health plans can't indicate why they're more than just a card in your wallet, and why they make a difference, they shouldn't exist. So we're trying to do a lot around population health and innovative plan design, how we work with providers, et cetera. But to your point, more and more of these models are becoming critically important in putting these out in place and working with the physicians.
What are the primary business lines for the organization?
So we have about 1.25 million members. We're in New England, Maine, New Hampshire, Connecticut, and Massachusetts. Massachusetts is our largest number of members, but we're primarily in commercial, and recently re-entered Medicare Advantage about 1.5 years ago. So, but primarily commercial historically. Some other things that differentiate us. First of all, we genuinely care about quality, and I think in a world where health plans are reviewed a little bit askance, only slightly better than elected officials in Congress, we don't fall into that bucket. We're reviewed as part of the community. We care deeply. In some cases, and frequently, we've made decisions that may be questionable with the evidence, but just driven to want to do the right thing. So even where we have policies or evidence that says, by the book, you would not, they purchase something with 20 PT visits, just a plan design, black and white, and they need more to continue to recover, we frequently do approve more. So we do more than we have to. We try to think what the right thing is for the individual, even though we're under a lot of pressure to manage costs by trying to impact inappropriate care, for example. But so we do have a quality focus. We were ranked number 1 in the country by NCQA, the National Committee on Quality Assurance, for 10 years. That's based amazing. On quality out of all the plans in the country. And it is, and it reflects the fact this is how we do business every day. We don't treat this as an exam to study for when they do the survey. We care about our members. We focus on identifying gaps in quality, HEDIS scores, and closing them, et cetera. So we're lucky to have a great provider environment here. But when you're number 1 for 10 years in a row, it's not statistical.
Right. Right. It's not an accident.
And I remember when I came here, I was in awe of their performance, and NCQA has actually just stopped ranking. They decided to stop doing that, and now we're kind of trenches, if you would, of kind of excellent, very good, et cetera. But I remember meeting the people that did that, and one of the things that any new organization is determining where do you focus and where do you not mess with it. And I said, look, I'm coming from an organization which had multiple health plans ranked in different parts of the country, and I think their highest ranked plan was like number 50 or 60. I'm going to stay out of your way. I'm not going to pretend that I can actually help you do your jobs better. I'm going to stay out of your way in this area and just tell me what you need, which I think was a good move. So the other thing about Harvard Pilgrim, we have our own institute that does research, which is a terrific resource for helping validate a lot of these cool things we're doing. And our institute actually incorporates the Department of Population Medicine at Harvard Medical School, where I have the pleasure of chairing their board of managers there and have a faculty appointment. So one of the surprises is that the chair of that actually reports to me and actually dotted line to the dean of Harvard Med School.
Wow.
And I don't provide a lot of direction to this person because he's incredible and way smarter than me. So again, I'm there. I try to help, but I really also try to stay out of his way because he's tenured Harvard faculty and just is brilliant at what he does.
Right.
The type of studies they do, and they actually do a lot of the research for FDA with their Sentinel project, where they use data from across the country in an appropriate way to identify early indicators of adverse drug reactions or other type of events, for example. So it's a great part of my job that I enjoy, and they're just an incredible organization, and it is a unique relationship. The way I explain it to people, if you go over to Harvard Med School or any med school, and you ask where the Department of Anatomy is, they'll point to a building. And if you ask where the Department of Physiology is, they'll point to a wing. And if you ask where the Department of Surgery is, they'll say, oh, there's no Department of Surgery here on this campus. You've got to go over to the teaching hospital. And by analogy, if you ask, where's the Department of Population Medicine, they'll say it is part of Harvard Pilgrim, which is a good place for it to be. So a lot of collaboration there, and it adds a dimension to the role that I would not otherwise have, which also makes it very attractive.
That's neat. So you were hired on as the Chief Medical Officer of Harvard Pilgrim. What does that position involve?
Well, ultimately, I'm accountable for the quality, and as part of that, the cost and value of the over $2 billion we spend on healthcare every year. And it's really thinking about how are we cost effective in managing really the what we sell to our customers. And so if you think about the components of that, I have a pretty broad accountability both strategically and operationally. So in addition to the Harvard Pilgrim Healthcare Institute, which I mentioned, my areas include pharmacy, including managing our formulary, and I chair our P&T committee, and we've got a team, and we actually do our own rebate contracting directly with manufacturers, which many organizations our size choose to leave to the PPM, but we think we can do that effectively. There is our wellness area. We're providing our wellness platform and incentives and working with employers. Our clinical quality area, working on the HEDIS and other scores and working to close gaps in care and improve the quality of care that our members receive. There is our care management, disease management. We have over 100 nurses who work from home providing either wellness coaching or diabetes or oncology disease management programs or complex case management to help serve our members better. We also have our clinical policy area and regulatory areas. Member appeals and grievances also reports up. And then there is our network medical management area, which is very near and dear to my heart, which I've worked with closely since being here. And that's the area that develops all of these innovative care management models and other ways of working with provider entities to figure out what are the right models. If we say, let's pay you for value, that doesn't mean anything. So they work in actually developing and piloting and putting in place these models.
Okay.
And then finally, a department that did not exist when I joined, medical informatics. And that's something where I asked people, how do you get the information you need? And having worked at companies like Ingenix and Thomson, I understood the importance. And when I asked, how do you get the information you need? I got an answer, well, it depends who you know, which told me there was a problem. So I put together a business case.
So there was no corporate solution at that point.
But we put together a business case, and we put together a new department and licensed some tools, and that's now really critically important, both to finding variation and improvement opportunities for cost or quality, and even more important now, for as we work with provider groups under these new models, we need to give them the tools and dashboards and the like. This is now critical. This is not nice to have. This is important. If we're going to give them greater accountability and they're going to take risk, how do we give them the tools that they need to actually manage the population? So it's kind of a broad swath, and then also kind of strategic planning for our area, and then working across the organization on many initiatives, working with the product people and supporting sales, et cetera.
So coming back to our discussion earlier about value-based compensation, you've actually written a couple of articles about some of the efforts that you guys are attempting to do here. In your article, Paying for Value, What's Next, you say that the challenge now is about how to transform our system to one that rewards value. And I was just looking at some statistics, and it said that we had talked a minute ago about fee for service, and back in '88, some 73% of employer plans were fee for service, and today we're down to about 1%. Mm-hmm. So how are you going about this process of shifting towards one that rewards value?
Yeah. So again, we had a experiment with capitation in the '90s, and a lot of people feel that did not end well. And so what I think was learned at that point is giving docs a set amount of money and saying, deliver the most cost-effective care possible, which then is not going to be the cheapest care possible, is not really good means for long-term success. And so what's changed is that everybody gets that, and we realize we need to talk about outcomes. We talk less about cost and more about value. What are the outcomes you're getting for that cost? So if you can think about it, quality over cost, if you would. So we're really trying to agree first on the outcomes, and then what does it take to get there, and coming up with fair payment that incentivizes physicians to think about what the right things are to do and not to think about what the things that get them paid the most. So for example, if you can manage a population and keep them out of the ER, and that, let's say, diabetic, and keep them out of the hospital, out of the ICU with the diabetic ketoacidosis, that's a good thing, obviously. Yet, if there are things you can do, let's say telephonic or virtual visits that aren't compensated, that you won't employ, that's a disconnect. So it's really trying to get away from you're doing what gets you a billable CPT code, which again, I don't even, and you could view that on an ethical framework, but there's also the real world framework is that they have their own salaries to pay and infrastructure. So you have to think about doing things that are sustainable long term, that are a win-win. So we've tried to come up with the right outcomes. So we're spending much more time on the right outcome models. We've got more sophisticated informatics systems to share data as we go. So it's not just here's some goals, but we'll meet with you regularly so you know how you're doing and provide you some portals and other informatics tools so you can manage the population better. It's having the population tools that we have that we can embed into these models to support the providers, whether complex case management or other types of programs. But it's also being flexible. And one of the big ideas is that one size doesn't fit all. And so another learning is if you tell docs either we'll capitate you or else not at all and you'll be disadvantaged, that may not be the right thing to do to force docs to take risk they're not ready for. And so what we've tried to do is come up with a more graduated approach and the idea that we want to pay everyone for value, but we realize that you may have a different level of sophistication or a different level of comfort than another group. So no matter what your level of population health sophistication or your ability to manage risk or your willingness to manage risk, we want something on the menu for you. So, for example, we have, at a population level, we have maybe 10% of our members who are fully capitated by groups that are very good at doing that. And again, we're very clear on what the equality measures are so that we're not paying, it's not, the goal isn't, you don't want the lowest cost provider, I don't want that for my family, you want the highest value. So it's designed to support that. But we also have a large number of our providers, the majority certainly in Eastern Massachusetts, for at least a portion of their population who are in one of these models other than fee-for-service. So for example, if you're not ready for full risk, maybe you're in a shared savings or shared risk model. So a shared savings model looks at the overall cost of care for your patients who are attributed to you, whether it's money paid to you as a doc or spent on imaging or ERs or drugs or things that didn't go in your pocket, and looks at the year-over-year trend for that population versus a broader population. And if your population does better, you get some of that savings. And in a shared risk model, you get some of that savings, even more of that share. But if it goes in the other direction, you may have to pay something back.
Okay.
So we're providing a pathway to acquire comfort and to work at different levels of risk with the idea of being paid for outcomes. We don't want you to say, I'm not ready for full capitation, can't work with you. And the other area where we've been very innovative, you want to think of the other axis, is these are great if you're comfortable managing a population, if you're configured to manage a population. What if you're a really good oncology group? What if you're good at orthopedic surgery, diabetes? Those models don't really help you. Right. So we've
because those models are primarily primary care.
Well, they're population based. They're for all aspects. So
okay.
If you're a large system like a Leahy, Beth Israel Deaconess, Atrius, et cetera, those can work well for you. But if you're New England Baptist and your expertise is orthopedics,
I see what
you don't kind of own the patient, you can't influence a lot of that.
Right.
So what we've done is try to look at what's on the menu for those groups, kind of on another axis, if you would. So we've done a lot with medical homes for primary care. We sat down with an oncology group and we said, let's figure out a model that works for you. Let's look at the medical home model, white out the things that don't make sense, and let's talk together. We're not bringing this to you, do it or else. Let's talk about the things you can do that can impact care, that can improve quality, reduce inappropriate care, whether it's unneeded ER or end-of-life care that isn't appropriate, et cetera. What are things you can do, but which you're not doing today, in part because you're not paid for or they're not part of the expectations? And let's build up that model where let's agree on those are the expectations and the outcomes, and we'll pay you differently in a way. We'll pay you base fee for service, but an additional care coordination fee that reflects that savings. And we're doing that with a large series of practices, Commonwealth Hematology Oncology, which recently got acquired by Dana-Farber, but they're still maintaining them as community practices, and we're working with them, and that's gotten a lot of attention, has been successful. We're doing bundle payments for procedures, whether it's for cabbages or even for colonoscopies. The idea that if we agree on on a procedure and the right trigger in the right period of time, and we pay you in a way that's fixed, you're going to figure out what have you been doing that doesn't need to be done, whether it's around post-op care or rehab or unnecessary lab work, and stop doing it. And we design these in a way that we and the provider practices share in that saving. So we look at what we think it'll cost, and we share some of these data models transparently, and we will show them, look, a lot of the patients here are going to ERs because they don't have post-op pain management. If you think more about prescriptions and about providing access after hours, someone who can call on a script and we can eliminate those, think of the dollars that go into this. So we're clear about what we think the drivers are. We also want to make this a win-win. So this is not a one-off negotiation like buying a car. At the end of the year, we want everyone to say, this is great, let's continue it. Not you outsmarted us because we didn't think about that.
Because you are in a relationship with these people.
Yeah, this is a lot of work. I mean, some of these can take 6 months to figure out the pieces before they go live. So we want them to work. We don't want someone to outsmart the other, say, well, God, we didn't realize that this care was delivered and it's in the bundle or something, that because of information asymmetry. So we bend over backwards to be fair, to course correct if there's a new drug comes out that should be part of a bundle, for example, and isn't priced in. And we agreed, for example, what about something catastrophic? The docs haven't signed up for that. So we agreed with most of our bundles, if something happens, let's say with a CABG, someone has a stroke or something, which is very expensive. We actually statistically drew the line at 2 sigma out, 2 standard deviations away from the mean, and said above that point it reverts to fee for service or out of the bundle, because it isn't fair to you to put you in that situation where a catastrophic event could wipe out all of the good you've done with all of your other patients. So it's really about sitting down at the table, being fair, and doing something that works for everyone, versus a typical contract negotiation framework under fee for service of, we want to pay you less, you want us to pay you more. So again, this is about how do we enlarge the pie through eliminating unnecessary costs. So that's, to me, a lot of the fun and very rewarding, and a lot of the docs are getting that.
Yeah. Could you briefly describe what you mean by a bundle? Because I know there's a time element to it. There's a number of things that kind of keep something in or out of the bundle.
Yeah. So a bundle is, in a sense, a DRG is kind of a bundle for the hospitalization component alone, just for the facility portion. We're trying to put this on steroids with guarantees. So an example would be a bundle. There's generally a trigger, and you can do this for chronic care. We're starting to play with diabetes. Procedures are still complex, but they're simpler. So let's say a total knee replacement.
Okay.
Or, it could be treating stage 3 colon cancer, but let's say a total knee. So we agree on a certain population. Let's say we'll have a different bundle for those with bad heart disease or some other or revisions, but let's agree on a certain consistent population. And once we agree that they need a total knee, we'll pay you through the bundle. And what that means is that all care after that point, all the pre-op work, the hospitalization, the rehab, the additional physicians who see that patient. So if an internal medicine does a pre-op consultation, that's included in the bundle. We're going to pay you this fixed amount, whatever the dollar value is. You're going to divvy it up. Although in some models, it's paid out and then recouped afterwards, which I don't think is effective managerially for influencing change. Get into the tragedy of the commons problem. Mm-hmm. Why should I be more efficient if he may not be and suck up all the excess? So we need an entity that actually is sophisticated. They can manage the pieces and the cash flows and manage the dollar payments to all the pieces of the delivery chain consistent with and commensurate with the value they're creating. But so it would include, for procedure hospitalization, all of the physicians, surgeon, anesthesiologist, the other physicians who may see them, post-op care, generally rehab, etc. And generally we try to go out to a certain point in time. Ideally a year or two. Sometimes based on the groups, they may not want to go out that far. So if there's a year, for example, that means that any additional care during the time that's related to the total knee, could be an ER visit, it could be a revision, it could be a hospitalization for infection or revision to the implant, you don't get paid extra for doing that. So we build in a little into the bundle based upon a cost allocation for that, if you would. But if you believe that those are that can be influenced by the physicians, which we think they can be, then it's fair to put that in there and to say this is now an opportunity for you to improve your margins by thinking more about what you do and you don't do. And there's a lot of evidence suggesting that those kind of models are very effective in driving care with the right partners. Again, we're starting to think about chronic disease as well, which is more complicated for reasons that are probably obvious. And beyond bundles, we're starting to think about outcomes-based payment for pharmaceuticals. So high-cost drugs are in the news lately, whether hepatitis C or the new PCSK9s for cholesterol. And each of those classes, for example, they're impacting our trend, our year-over-year increase in spend by over 1% each, by one new class of drugs. And I just gave you 2 examples in the past 2 years. So pharma companies are historically paid for pills, right? They don't know or care what happens once it, and we're talking more and more, no, you need to be paid for solutions. We're paying everybody else for outcomes. You need to get with the program.
Really fascinating.
And again, you're getting a lot of here's why we can't do that, but we're starting to push pretty hard. That's when we're in the very early innings. And we're starting to talk about, okay, so Novartis say your new CHF drugs reduces hospitalization by 21%. And again, given there are data challenges and population identification issues, yes, but are you willing to pay us back some of our money if we don't see the hospitalization drop by that amount? Hey, it's your data. We're not asking you to commit to something. That's what you said on it when you applied for the FDA labeling. So,
right.
And again, initially it's here's why we can't, and now we're starting to push them. And particularly where we as payers are being more selective, so more and more we're likely to say, yes, you can have this one Hep C drug, but not the other. And we're likely to do that with other classes as well, where we see them both as being highly effective and equally safe. A lot of our decisions relating to our formulary are likely to be around, are you willing to change the thought process to one where you're putting your money where your mouth is?
Wow, what a fascinating idea.
So that's cutting edge and as part of the fund as well.
Yeah, neat. Looking at it kind of at a strategic level, we've seen a lot of consolidation with health insurers over the last several years, particularly after the passage of the ACA. From your perspective, why is this happening?
Well, I think there's a couple of things going on. Number one, there are certain benefits in economy of scale. So when you talk about something like the exchanges, which is a fear they could promote commoditization, everyone's looking at the lowest cost premium, there's more pressure to reduce cost. And certainly taking an expensive claim system and distributing the cost, if you would, among 20 million lives instead of 2 million is clearly more cost effective and allows for less of an administrative overhead. That's one point. And some large payers, they're spending hundreds of millions of dollars on their web portals on how they go retail and engage consumers. As a smaller plan, you don't have the resources to be doing that. Another issue is that, and this is kind of an arms race, there is benefit to strengthen contracting. And again, there is some restrictions that the FTC looks at, but we see the providers consolidating very quickly.
Okay.
So there's
a little bit of an arms race?
There is a bit of an arms race. So in some cases, the providers have a lot of market power, and if you don't represent a large population, you're worried about your ability to negotiate favorable deals, based on contracts.
Okay.
I think there's benefits of being smaller. We're more nimble. I can come up with a new outcomes-based model and get it through here a lot quicker than many of the larger entities. So there are benefits to being nimble, but that is what is driving that, and I think it's likely to continue, in the industry.
I'd like to transition and talk a bit about leadership. What would you say is your leadership philosophy?
Hire great people, build the right culture, and where everyone feels respected and heard, and work with your people to develop the right outcome measures, and then kind of get out of their way and figure out who needs help and who, for whom is your help creating a disruption. And so choose where you focus, but really focus on the outcomes and get everyone on the same page. I'm really proud of the fact we do our employee surveys every 2 years, a large Gallup survey, and health services always comes across at the top, generally above the national averages and above the best-in-class 90th percentiles. And we look at, do people like and respect their colleagues? Do they feel valued? Do they understand what they're accountable for? Do they have the tools they need? I mean, this stuff is not rocket science, but it's really how you work with people every day. And I guess the real lesson for me here is when I think of the individuals who've inspired me and the bosses I've had where I want to go to work every day and do my best and help them be successful, they make me feel like I'm part of the team, like I'm important, like they care what I have to say, and like it's us, as opposed to like it's them giving me direction. And similarly, I've tried to learn from that, respect the people who report to me, treat them as colleagues, and peers, and and build that type of relationship as well. And and I think to a large part I've been successful. Certainly with Harvard Pilgrim, it's really the best group of people I've ever worked with. So just a tremendous environment here.
What would you say are the characteristics and behaviors of a good leader, and how do you aspire to those yourself?
I think they have integrity, they're honest, they're transparent, and they care about the people they work with. And again, easy things to say, but again, I've been in organizations and learned a lot by watching, bad examples, which I think are the best way to learn lessons. So, a lot of these are obvious. I think you need to, if I'm not genuine, people can tell. If I'm not saying what I mean, I'm not very good at hiding that. I think most people can tell that better than others can think. So we all know people who we think are kind of full of themselves or saying what you want to hear. And my theory is people around you are very good at picking up on that. So be genuine. Also, a few other things, be clear in outcomes, address issues, don't let them fester. And and have the difficult conversations. It's very easy to not want to deal with conflict, or to want others to deal with it. But there's frequently conflict, particularly when you're going through periods of rapid change. And some people may be taking on new responsibilities. Others, you're carving up things differently. And people who are passionate about what they do sometimes. They're focused on their view of the world, and if they're losing some responsibility, they may not be happy about it. So really just try to think about how they're, understand how they're looking at the world, but also address the conflict head on. And again, to the extent that you value people around you and they know that they feel valued, you can generally work through issues.
Can you give an example of a difficult leadership lesson that maybe you had to learn the hard way?
Well, I mean, a mistake I've made and regretted is moving too quick to hire someone who, because you've got a burning need to fill the position.
Okay.
And it's particularly tougher in the for-profit world. So I've been in situations where I felt pressure to hire someone, and I've been told if you don't hire them, the dollars are going to go away. In other words, you won't be able to at all. So it creates a lot of pressure to hire someone before that happens, right? And particularly in a for-profit world where budgets are tight. And if the financials get more challenging, they tighten up. And so there are one or two cases where I've ignored my intuition, had someone who maybe had a good resume in the pieces, but I just worried about their cultural fit or something about their competencies, or there was something gnawing away. And you could convince yourself, you could ignore that and convince yourself that they kind of met the job description objectively. And there are two cases where I've done that, and both where they turned out to be disasters. And it takes a long time to manage someone out of an organization.
Yeah.
So, I guess those are difficult. And the corollary to that is good leaders do make mistakes, and it's okay, but acknowledge it. And if there are relationships that aren't working, someone's in the wrong role for them, or you've made a hiring mistake, take it head on and manage them out. Do it in a way that's humane. If it's just a poor fit, acknowledge it. Sometimes HR likes to create performance improvement plans and make it hard. But there are points where you just sit down and say, look, this is just a poor fit. I don't think this is working. And frequently they don't think it's working either because they're aware of it, and agree on some severance and a path to exiting the organization or the role. So I think many people, because those are hard discussions, and it's something I think a lot of people avoid until a situation gets so bad that it's something that could have been handled better earlier on.
Well, it's going to take a lot of courage to do that, though. I mean, it's not an easy thing to.
It isn't, and it's something that a lot of people are uncomfortable with, but again, ultimately it makes them more effective managers, and it is something you need to be able to do if you're managing a large number of people. I mean, there will be mistakes, there will be changes, there will be people who were effective in one role, the role changes, the organization changes, and they're no longer effective. And it helps to remind yourself that ultimately you're not doing them a favor if they're in a role where they're not being successful.
Okay. Can you give an example of a leadership challenge that you're particularly proud of having met?
Yeah, so I was in an organization where I had an employee who worked in another market. And he had a dotted line relationship, and he was responsible for a very large and influential customer. And because they were so influential, they were getting a lot of attention, probably the most of any in this broad organization. And leaders were coming to that market and not even including him in the discussion, so he's being bypassed. So not surprisingly, he kind of feels, a little bit, disengaged, and it's showing. And he's a little bit of fatalistic. Well, why should I pay attention to this? No one's asking me anyway, and you're leaving me out of things that I should. And he was right. Yet it was something which, leadership said, this is our most important customer, we're going to be hands-on. And there were some challenges in helping them meet their trend challenging, their cost challenges in the market, and he wasn't grasping it. He wasn't. And I remember being in a meeting, and he was on the phone, and I was with some senior leadership, and he wasn't. You could tell he was disengaged, and I knew this was a very bright person who was, had been very effective in the past, and so someone very senior mutes it and goes, "I want him fired." So which I thought was unfair to him, and it was a wrong decision for all parties. So I said, I'll tell you what, let me work on this and see what I can do. And so what I did is I sat down with him, tried to shake him up a little bit, but also protect him from a bit of that help. And I spent a lot of personal time putting together a strategic framework for how we worked with this large demanding customer. Looking at certain areas, what do they want? What's the overlap? And helped develop a very focused plan for addressing, which was very well received. I then stepped out of the way, made sure he was given credit for that. He now is more engaged. The people who want them fired no longer wanted him fired. I didn't have to replace a difficult position, and things worked out well.
Nice. What do you look for when hiring leaders and evaluating those leaders?
I look for people who, so first of all, I look for people who understand the business. And we get a lot of people who sell leadership. And leadership is kind of a vague phrase, and there are some good leadership characteristics. But one of the things I've learned, particularly in healthcare, and particularly in environments like the one I work in here, I have a lot of really smart people. They know their business. Now, in most cases, in some aspect, and I really hope this is true, I hope I'm the dumbest person in the room. And I want to hire people who want to be the dumbest person in the room too. So if I'm sitting there with my pharmacy people, some of them, pharmacy degrees or not, they know far more about a lot of this stuff than I've forgotten. And my NC Care regular, she knows more about this, and that's healthy. So you need people who have a strong enough ego that, first of all, that they want that and accept that, understand that's really important in management, which clinical people, particularly MDs, don't always get. So that's one piece. But you also need enough domain knowledge. So when I've hired, particularly for more leadership roles, and you get people who are like, I've never done this job exactly, but I bring leadership. Well, and I'm thinking you need to know enough about the fundamentals of the business or that area that you'll be taken seriously. Otherwise, you're going to be eaten alive. And some people don't understand that. So leadership is important, but it's also good to have enough domain knowledge. And one of the things I've noticed in my career is that really good, impactful leaders can understand that, and they know enough. So when I look at I spend a lot of my time at a high level and strategic, but I also can sit down and do a deep dive into an area and have a good discussion and ask questions that indicate that I'll pick up on something if it's missing. So if I didn't have that domain knowledge to be able to go and get into the weeds and talk intelligently about that, I wouldn't be respected, I wouldn't be impactful. So part of it is knowing enough that leadership isn't enough. You actually have to understand the details. And when I see my fellow leaders here who are generally very, do a very good job and very effective, and you'll see that they all are people who know their businesses. They're not up here, they can do a deep dive into the specifics of any area under them. And again, so finding that those people are really important. I'd say humility. Understanding that if you're leading a team and if it's about your ego, and there are people coming in and it shows very, very clearly. Are they using words like I or we, or talking about how their teams have helped them or what they did before? And again, you can talk about your own accomplishments while acknowledging that a lot of it is driven by others. And certainly the job I have, I think the role is important, but most of the things that get executed get done by others around me. Hopefully, if I'm helping them and making their job no more difficult, many would say that's a win. But you're really impactful through others the more and more senior you go, and you need to understand that. also, particularly for clinical people, and MDs are the worst of all. You need to understand that you're not getting paid for your credentials. You're getting paid because you're doing a job and you're having an impact. And there's a lot of people who you'll interview and they see their job as, well, and they'll say this in an interview, well, it's to be there and to give advice if people ask me questions. And I'll say, no, you're accountable for the trend in Maine or New Hampshire or whatever. You need to understand what's happening with the cost drivers and be managing that and determining if there are ways to engage. You need to be working with the physicians around these new care delivery models. You need to be out supporting the sales team, and here's how we're measuring success. So you're accountable for these, not show up for work and you'll get paid. And again, clinical people, because if you're in a clinical specialty, MD or otherwise, you go to work, you get paid, you kind of do what you're told to, versus having to make sure you're driving value. So certainly you can go to work every day in a management role and for quite a while not really be doing anything substantive, kind of moving pieces around, and but ultimately that job is found not to be needed. I mean, probably the worst example. This is kind of a poster child for what not to do in terms of hiring. So I was at at the start of Health Allies years ago. We were at a conference, and this physician came up to the CEO and said, "I really want to work for you. I think a physician like me would be great to help you." And the CEO very, very adroitly put his arm around it and said, "That's great, you'd be great. Let me introduce you to Michael." So he then said, essentially, "I don't really understand, all of what you do, but I think it would be great to be a part of the team." And so I told him a little bit, and he said, "I'll send you my resume." So he sent me a resume and cover letter. He was an MD and MBA, primarily a practice, never got a lot of the lessons we're talking about here. And in the letter he sent me, which I still remember clearly, I posted it, of course, which probably got defaced by others in the office, but it said, "Hi, I'm the physician who came up to you and didn't know what you guys did but wanted to work for you." I'm thinking, okay, well, thanks for reminding me of that. And now I've looked it up, and I see that you're creating this provider network for ancillary services, and I would love to be out there with you. Nothing would make, I think would love to work with you on flying into a market, playing golf with the physicians, and take them out dinner and trying to get them. And I'm thinking, is that what you think I do? That isn't. I'm thinking, I want that job too. Clearly, so there's sometimes a thought of that I've gotten to a certain point in another aspect of my career, I've earned something and you'd be lucky to have me, versus understanding here's what the job entails and here's what I can do for you.
Yeah.
The other thing I'll say in hiring in general, and I think this is something most of us do intuitively, you hire someone for one of two reasons with respect to competencies. Either they've done the job before, or they have the skills and competencies and they haven't done that job before, but they've done a different job, and you think that they have the skills that they can learn the piece that they don't know and take it on.
Did you mention a couple of mentors kind of in passing in our conversation? How did these people help you, and was that a formal or informal relationship?
Well, I've had several, all informal. I've never been in a formal mentorship program as a mentee, but I've had several who've been informal mentors, and I think it's very helpful to have people who are in a role more senior to yours. Generally, she should not be your boss, obviously, but where they can serve as a sounding board, if nothing else. In some cases, they may indirectly lead to jobs or board seats, and that all of that has happened to me. But most importantly, it's someone you can talk to and objectively be a sounding board. So when you're considering a job change or a challenge at work, and someone who, again, you've got a good trusting relationship, a sense of confidentiality, and you need someone who can tell you, no, you're not saying this correctly. I think you're making a mistake, for example. So I think that's important. More and more there's more formal networks. We at Harvard Pilgrim provide mentors for employees, again, in other areas of the company generally. And there's an industry trade association, AHIP, America's Health Insurance Plan. I'm now serving as a mentor for the third year for a chief medical officer from another organization, or someone who is in that role, or a more junior role, who is aspiring to be a CMO. And so, I speak with them monthly, and they do a site visit and meet with myself and my team. And so I found that rewarding. I enjoy engaging those people. Again, they're all really bright, high potential or they wouldn't be nominated by their organizations for this. So, they hopefully learn something. I learn, they pair us up with people in other parts of the country whom you're not competing with. So I learn about them as people, about lessons they've learned, about how they do things in their organization. So it's mutually beneficial, and I enjoy it.
You just mentioned AHIP. What other professional organizations are you a part of?
AHIP, there's many. AHIP is one for on the health plan side. There's another one, the American Association for Physician Leadership, which is formerly the American College of Physician Executives, which a lot of MDs who are in or aspiring to these kind of roles. There's also the American College of Healthcare Executives for non-clinician or clinicians in the healthcare space, which is terrific.
Are you a member of ACHE?
I've actually let my membership lapse. I was, but I just can't even keep
There's
up
so
with
many
everything.
things. Sure.
But also people should think seriously about alumni associations and other affinity groups. So, for example, at Harvard Business School, I've been a member of, and I'm a board member, and I'm actually co-president of the HBS Healthcare Alumni Association. So now I'm part of the leadership there, but I was a member for many years because that gave me access to people in healthcare leadership positions, fellow alumni getting together for conferences and other things. And you graduate knowing people in your year, but you don't know those who are 5 or 10 years out. And this really brings everyone together and has provided a lot of networking and growth opportunities and been a lot of fun. So to the extent that you're part of, you're an alumnus of an organization that has some sort of particularly healthcare related group, I'd suggest getting involved and not just joining, but helping lead it and helping do programming, which is a great way to really broaden your network as well as learn.
So, final question. Based on your experiences, what advice do you have for clinicians who are thinking about making the transition to a management role?
I think there are more and more opportunities as we go from being a cottage industry to one which needs to be de facto well managed, and which is, again, going to an environment where more physicians are employees. They have bosses. They need to be managed. The systems all need physician and other clinical leadership. So there's more and more opportunities. So I think it's great, and I think in many cases those with clinical backgrounds are well positioned to do these jobs. The caveat I would remind them, the most important piece is it's a different mental framework. You need to be able to check your ego at the door if you're going to be effective. The things that work clinically, that people will listen to you by dint of your doctor so-and-so, will hurt you if you want to be on the management side. The other advice I would have is become educated, whether it is through seminars, through an MHA or MBA or MPH or other education. This is a skill set, and there's knowledge to be appreciated. And I think in many cases, clinicians who've taken courses in pharmacology or organic chemistry and others, where they're very objective, data-driven, don't get the softer side of management. And the one thing I've seen, the thing that separates those who are successful from those who are not, it's not the underlying intellect. Most people at this point have enough brain cells, have enough IQ points. What they need are more EQ points. It's that emotional intelligence that determines whether they're successful. So search yourself long and hard and make sure you understand what that is, and if you don't have those pieces, again, do some coursework or some learning or some self-reflection before making a decision.
Thank you so much for your time today. Appreciate you being part of the program.
You're most welcome.
You've been listening to the Health Leader Forge, a joint production of the College of Health and Human Services at the University of New Hampshire and the Northern New England Association of Healthcare Executives. Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll talk with you again in about 2 weeks.